standard treatment for metastatic urothelial cancer is platinum-based chemotherapy. That's been the case for decades. Treatments generally continued for approximately 6 to 8 cycles and then discontinued given concerns for cumulative toxicities in the context of diminishing benefit. And usually at that point we stop treatment and we wait, and most patients do experience disease progression, oftentimes within a period of months. And so there's been this concept of switch maintenance therapy. Should we take a non-cross-resistant treatment and apply it immediately after stopping first-line chemotherapy? And that's the concept that we tested in HCRN GU14-182. This is a randomized Phase II study testing the concept of whether or not switch maintenance with immune checkpoint blockade, specifically pembrolizumab, could extend progression-free survival in this setting. It was a 1-to-1 randomization in patients who had received up to 8 cycles of platinum-based chemotherapy and had at least stable disease. Patients were randomized to placebo versus pembrolizumab. Pembrolizumab was continued for up to 24 months in the absence of disease progression. The primary endpoint, progression-free survival, was met. Pembrolizumab was associated with a significant prolongation of PFS in patients receiving pembrolizumab compared with placebo. Certainly there are toxicities associated with pembrolizumab. We saw those same toxicities in this patient population. We didn't see anything that wouldn't be expected necessarily with pembrolizumab. Interestingly, because this was a double-blind randomized study versus placebo, some of the side effects that we often think about with pembrolizumab, rash, pruritus, diarrhea, increase in hepatic transaminases, we did see on the placebo arm as well. So these things do happen in patients with cancer, happen in patients taking other medicines, but of course some of these class effects were increased in frequency as expected on the pembrolizumab arm. The role of switch maintenance therapy in this disease will be refined within the next 12 to 18 months by the results of several large randomized Phase III studies that are completed in accrual but haven't been reported yet. And those studies are really testing two major concepts. Should we give immunotherapy with chemotherapy all up front, or should we just give immunotherapy up front? Or should we do what we did in this study? Should we give a switch maintenance approach? And looking at all of the results of those trials in the context of these different treatment strategies, the risk versus benefits, and the ultimate outcomes, that will help select which strategy rises to the top in terms of our new standard of care.